So good afternoon, everyone. My name is Lillian Cow. I welcome you to this session on ERAS and ambulatory surgery. I got Dr. Claro here as my co-moderator. We will do the talks and the questions as together. So please have your questions straight after the talk. So it is my pleasure to start off this meeting with the first talk. Is pre-admission ERAS beneficial for the surgeon or the patient? I'm going to invite Dr. Peter Samuel Billing to come up to the stage. Dr. Billing founded the Transform Health Partners and Transform Weight Loss, and he has a successful bariatric surgery program in the Pacific Northwest with clinics in Seattle and Portland. Welcome.
Thank you. Thank you very much. Do you have the mouse? There's no mouse here. We're good. I think we're good. Well, I'm glad to be here. The message I want to give today, I think, is a very important one and relevant to our society and profession. And ERAMS or ERAS became a necessity, especially during the pandemic when so many cases were shut down. And our hospital would allow us to do Daycase. If patients need to spend the night, the patient could not have an elective operation. So I'm going to start off with this talk with a bold statement. Most metabolic bariatric cases will be Daycase in the future, and I think this is going to happen over the next five years. Currently, I do 99% of my cases as Daycase, and maybe I cherry pick. I don't think so, because we do revisions and gastric bypass and SADIs and all this complicated stuff in the surgical center. But to get from A to B is a challenge. And that's what I really want to focus on as the talk is, if you're interested in doing ambulatory or Daycase bariatric surgery, this is basically the toolkit on how to accomplish that. Starts off with Legos. Some people here grew up with Legos and playing them, and a lot of us surgeons did that, and then we advanced to video games. Well, if you get really good, you can make a car. And you're going to start to make a really nice car, a vehicle that will allow you to do ambulatory bariatric surgery. I started this in 2008, and we've done about 5,000 plus cases as a Daycase. It really takes a team, and I would say the top thing on that team is the surgeon. And unfortunately, in many hospitals, the surgeons has lost their authority and autonomy to make decisions, to even hire and fire personnel in the OR. If you don't have an A team, you are not going to get the results that you need. This fundamentally affects patient care. So this is why I have stayed independent. As much as I enjoy working in the hospital with the team there, really we have a much more powerful team when we can curate and organize and keep the strong team members. ERAMS protocol, or ERAS, is essential into doing it safely. And that's where I'm going to get in the nitty-gritty. You need to set the expectations right from the get-go. That starts in the office, and then it goes to the surgical center, and then the aftercare. If you set the expectations, everyone knows what's going to happen. If there aren't the expectations set, if you do try to do these cases in the hospital, which you can as a day case, guess what? The PACU nurse is going to give the patient 200 mics of fentanyl, and they're going to be snowed, and they're going to go to the floor. And once they get to the floor, they're not going to get discharged the next day. Patient expectation 2, so they're going to say, well, why shouldn't I have my case done at the hospital? Well, that was a common question 10 years ago, but today, oh, why are we going to the hospital? I heard this could be done outpatient. And then the institutional support, where if you're at an ambulatory surgical center, you're going to have the support of the other physicians that usually are part owners and have a vested interest in making sure The surgical's reputation remains strong. The team is absolutely the thing. As we know, teams in hospitals, people come and go. I can remember multiple days doing day cases with various people at certain levels, ones that have never even fired a stapler or know how to put a staple load in the cartridge. It's very frustrating, even anesthesiologists and anesthesia personnel who do not know how to give anesthesia to a person of size. But when that comes together, you've got a Formula One race car. It's like putting on a fine suit. It's like going home and being amongst your family, because you got your patients who usually adore us, and now you've got your staff who love working together. So there's many threats to metabolic bariatric surgery. So I'm going to talk about the threats, the solutions, the background, our outcomes, and then really just give you the nuts and bolts and how we do it. These are the concerns, and this is why these are the naysayers. There's declining surgical volume, declining reimbursement. There's a bias against bariatric surgery, decreasing insurance coverage, reimbursement. GLP-1 drugs have dropped the numbers, the economy, political climate. There's a host of things that say, hey, I don't think bariatric surgery is going to grow. In fact, it's going to peter out. And the other concerns are safety. I think that's the number one biggest issue is you do the surgery and they send them home and the patient bleeds at home. The chance of that happening, unfortunately, is really low today with the technology that we have. So I'm very thankful for the instruments we have. I quote patients about 1 in 200 for a post-op bleed risk. The rest of the stuff really is got to do with cardiopulmonary issues. As long as your patient has a good heart and good lungs, they're going to do fine, and the surgeon keeps the case under 2 hours. Equipment, training, reimbursement, accreditation, malpractice risk, setting expectations, protocols, all of these things have to be built into a system. And without laying the groundwork, you're not going to have success, and you're going to have complications. The benefits is improving access to care. And I think all of us really want to increase the volume of our numbers, but that's going to have to happen by dispelling myths and lowering the threshold of the cost of the procedures. This is a big battle that we're all facing, and it's going to take time. You got to have a dedicated team, and when you do, it's awesome. Consistent messaging. What we find is the patient satisfaction is very high. It's much higher than the hospital setting, and there's various reasons for that. But the most important thing from a surgeon perspective, you can have autonomy. You can decide which staplers to use. You can decide how you want to do the surgeries, and you get equity, meaning you could have shares in a facility that you won't have if you are employed in a system. So the foundation of Daycase Bariatric surgery really was started in the gastric band era. And I'm really standing on the shoulders of people that did a lot of lap bands in the ASC. And the first paper I'm going to recognize is this paper up from Seattle. So this clinic and surgical center is literally 5 miles from us. They're our competitor, and we do cases at our competitor's ASC. We need to work together. And if we don't work together, we will be eliminated. But the results were good. And then they produced another paper with 2,000. So this had 300 patients in it, Daycase, and then they did 2,000. And we just followed this playbook. And we did it with gastrointestinal stapling, mainly in sleeve gastrectomy. And the reason why sleeve gastrectomy lent itself so well to the surgical center was because it was less complicated than a Roux-en-Y bypass. And at the time, the insurance companies would not cover sleeve gastrectomy. This was 2008. So we had these patients who had to cash pay in the hospital for their surgery, and we could do it for half the cost in our surgical center. And we were also getting really good results, seeing the patients that evening or the next morning, and we knew they were going to do fine. So in 2012-13, I published this first 250 consecutive cases. And the results showed that the complication rate is low. It's pretty on par with other types of cases. So if you look at lap choles and hernias and things like that, it's about 1 in 100 that someone ends up back in the hospital. The biggest concern, even back then, was post-op bleeds. And we had 2 out of 250. No one died. No one had like some unexpected complication that was directly related to being in an ambulatory surgical center. This is a very important slide because people ask, well, what are your criteria? This is our criteria, and it's pretty simple. We developed this from the get-go, and we really haven't modified it all that much. I think the biggest game changer was sleep apnea clearance. At the time, people were getting lap choles and dying from them, or they're getting total hips because they had untreated sleep apnea. Well, the same thing has to happen with bariatric surgery. Then we looked at high acuity and low acuity. That's defined by the MBSA QIP. We found there was no difference. This is an arbitrary designation. Low acuity is only allowed to be done in ambulatory surgical centers, but we did high acuity patients for a long time and continue to do high acuity patients in the ASC. That means revisions in elderly. No, we have not seen a difference in outcomes. So, this is just going into the paper. We did 120 cases, and the data is unchanged, but the readmission rates is higher with higher acuity patients, but it wasn't due to the place of service. Then we had a retrospective study of 3,000 patients done in multi-centers across the country, and we showed that it was safe. And then I published a single center in 2019 of 2,534 cases. These were really just all comers. Most of them were sleeves, but some were band to bypass, some were band to sleeve, VBG, take down to sleeve, VBG to bypass. I mean, we did some really complicated cases safely in the ASC. Finally, the past 5 years, I've been trying to replicate these at other surgical centers in our area. So there's another city about 250 miles from us called Portland. I'm up in Seattle. I went down there and developed a program. There's also a neighboring ASC that we developed that. And the demographics are from ages 18 to 72. And our highest weight was 416 pounds. Our highest BMI was 68. You can see on the list we did SADIs and Roux-en-Y's, gastric band removals, revisions. Most of them were sleeve gastrectomies, but we're comfortable doing most procedures. And what I showed is over time, when you replicate this, you can get better and better at the outcomes with fewer cases. So this is a operative time at the 3 facilities. They were done at different times, almost kind of consecutively. And the last one only has 14 patients in it, but we were already doing better than the second ASC. And average operative time was 40 minutes, and recovery time was under an hour. Same with the PACU times. They're all down. They continue to come down. So what this means is we can replicate this process at another surgical center. And the only difference was, well, it was just having the one surgeon who's got experience. And then my partner here is Dr. Eric Harris. We've been doing these together since 2011. It's great to have a partner, but I went to these centers without a partner. And the surgeons there and the nurses and staff never done a sleeve gastrectomy or bypass. So again, this is the criteria that we use. These are some of just important concepts on how to execute and get this done. We always give IV fluids, 2 to 4 liters, just to help with any dehydration issues. We're not having patients come back the next day for fluids. We're not checking on their vitals the next day, but we do call them the next day. And minimal use of narcotics, minimal use of drains. Drains cause pain. Toradol, Decadron, these drugs are very good intraoperatively. Very low amounts of fentanyl are essential. Here is the medication list that I use, just so you're aware. This protocol is, I think, stone solid. I see people presenting recipes for success for nausea and things of this nature. This works, and we've proven it over thousands of cases. So lessons learned, you need an experienced surgeon. You got to use these protocols. They need to be in place. Everyone needs to know what the protocols are, especially the patient, but your ASC staff. Set the expectations. Patient selection is key early on. Start with low BMI, simple cases, build it up. Maybe it's only 10% of the cases you see you're going to do there. Then it goes up to 30 and 40 and 70%. So daycase surgery is safe, decreases costs, improves access. It's an alternative to medical tourism because patients are leaving our area to get care elsewhere, but they're not getting the aftercare. And I think most of you can do this safely, but if you don't, the economic drivers are going to force you to do it at your hospital as an outpatient or day case. It's happening. It doesn't matter. And in the market, people are looking for less invasive options. I know we talk about doing complex bypasses, but the reality is patients don't want them. And you can't force it on them. They're just going to say, it doesn't matter, the outcome's better. The bottom line is that the market is what it is, and they want reversibility, they want safety, they want a really good experience, and they want a low cost. And certainly, they want durability. The future is bright. Thank you very much.
Are there any questions from the audience? I mean, the results are good. You have a low rate of readmission. Can I ask, do you have someone on a 24-hour on call to take calls from patients that go home in case, at midnight they got,
absolutely.
they got
I give them my cell number. I tell them to call me.
And
I give them my partner's cell number. I tell them to call me. Communication is absolutely key to the success. There's nothing worse than someone calls the phone number and they can't get a hold of their doctor, and where do they end up? In the emergency room. This is true, it's done at the hospital. So we got dinged at our hospital on the MBSA quit because patients were going to the ED. Yeah. And it's like, I told them, just give them your number. They, I don't want to do that. They'll call me too much. I haven't seen that. I mean, I've been doing this for almost 20 years. There are some patients that will abuse it, but you can like block them. But that rarely happens. The most important thing is that first night, if there's a problem, you got to be able to talk to the patient, and they need to talk to you.
So you sleep well every night?
I do.
You don't get too many
I
phone
sleep
calls?
well. I sleep very well every night. Yeah, these are the patients that are not coming back. The ones that worry me are the Roux-en-Y patients who've got an internal hernia, and that can happen anytime. Those are really the only cases that keep me up at night and have me come to the emergency room. Not these sleeve patients. They're not having leaks. Bleeds are pretty rare. They're about maybe once every 2 or 3 years we'll see a post-op bleed. So it's going to revolutionize surgery, and the sooner you get on board, the economic drivers are going to force it. We can present the data and the safety, but really the insurance companies are forcing it today.
There's a question there. Can you turn the mic on? Thank you. Should be on.
Can you show me the timeline of when the patient come to you and what you do the first time for the patient, like sleep test or the endoscopy time, like that?
Our protocol to go into the OR is the same whether they're done at the hospital or outpatient. What the differentiating factor is cardiopulmonary issues. If they have severe sleep apnea, or moderate severe sleep apnea, they have to have a CPAP. So I'd say about 90% of the people who come to us get tested. The other is cardiac. If they have any cardiac history, they're going to need some form of clearance, either an echo or stress test. And they have to be rated as category, the lowest level.
And you do the pre-op diet, like something like that?
Pre-op diet, we use a low-carb diet, but I think any of them seem to work, but I just don't like people being on liquids for a month. Yeah. So the protocol is very straightforward for pre-op. It's basically, they don't pass an eyeball test, they don't ambulate, they've had a transplant, they're like elderly, but elderly decrepit, they're just non-functional. But we've got many 70-year-olds who have farms and they're very active, and they're healthier than some of the 50-year-olds we operate on at the center. Okay, so thank you very much. How many people here have a surgical center or work out of a surgical center? Just Dr. Harris? Yeah? Well, I don't know about worldwide. I think the the concepts are very applicable to no matter which country you're in, but in the US, things are gonna rapidly change, and the economics of bariatric surgery are gonna change. But this is gonna be a very good thing for all of us, because it's gonna improve access to care. And people are gonna say, okay, it's a lot safer, it works, I've been on a GLP-1, and guess what? I need something more durable.
For your presentation. I'm Silvana Lapi from Uruguay. In my hospital, still we don't have ERAS for bariatric. Yes, for another specialties, but for bariatric no. And I would like to know if in your program there is on the protocol people must live nearby or some kilometers over there.
Absolutely. So we have a regional practice. We have people come down from Alaska, which is like 1,500 miles from us. The requirement is if they live more than an hour from our center, they have to stay in a hotel the first night. Yeah. Absolutely. If they're coming down from Alaska or Montana or a long ways away where they have to get on a plane, they have to stay in the area for 5 days afterwards. They're examined, making sure everything's okay, and then they can get on a flight.
Thank you very much.
Yeah. One other thing that we found that is really, really helpful to prevent DVT, because that was the other biggest concern, is we started using Eliquis, 2.5 milligrams BID for 30 days. Works wonderfully. We've had no bleeds, no issues with it. And Dan Cottam wrote a paper where 3,000 patients were taking it, not one DVT. So bleeds and DVTs are the biggest threat, I think, to bariatric surgery.
Great, thank you very much.
All right, thank you.
It's my pleasure to invite the next speaker, Dr. Anupama Wada. She's a professor of anesthesiology and a director of faculty mentoring and advancement at the University of Texas in Dallas. And Professor is going to talk on, I just lost my page, how intraoperative care has changed my practice, anesthetist view.
Thank you, Dr. Cow. It's been truly a pleasure to be a part of IFSO 5 years in a row. The previous talk was perfect segue into my talk because I feel that a multidisciplinary team approach is the only way to be able to send patients home the same day. And we know that we have changed the length of stay in multiple surgeries by surgery-specific ERAS pathways. And there is a definite trend that most surgeries will have shorter and shorter lengths of stay. And I absolutely see this, the trend of a sleeve gastrectomy going towards an ambulatory surgery procedure. So these are some of the trends for ambulatory surgery, and the expectation is that currently we have about 125 million surgeries that happen on a day case basis. This is likely to go up to 235 million in about until 2033. So early recovery after surgery has changed the way we practice in multidisciplinary ways. Definitely surgeons, anesthesiologists, dietitians, physical therapists, everyone has to work together to make sure that we work together to reduce the complication rate by about 30 to 50%. The moment we reduce complications by increasing the quality of care, we reduce the recovery time. And that's the whole purpose of ERAS pathways, that the patient is able to return to their physiological function, the preoperative physiologic function, as soon as possible. And that is only possible if we reduce the amount of pain, reduce the amount of nausea and vomiting, make sure that the patients are prehabilitated. And I absolutely love the bariatric surgeons because that is the only surgery where the time between the patient sees a surgeon in their office to the time the surgeon comes to the operating room table, sometimes it's time of months because they truly prepare their patients well, both physically and psychologically, nutritionally, and in terms of physical activity to make sure the patients are as optimized as possible before they start to cut. So this is truly one of the best, these are truly one of the best prepared patients that I find in terms of surgery. So the core principles of early recovery after surgery do require that we provide the highest quality of care to our patients that lead these patients to return to normal physiologic function. And one of the best ways to do that is to reduce complication rates. Because the moment the patient has a single complication, whether it's anesthesia complication, it's a surgical complication, or something to do with their psychological preparation, it's going to delay the care. It's going to delay their recovery, sometimes by days, but sometimes truly by weeks. So it's really important that everything is precise. It's precision medicine all around to reduce that complication rate, which essentially leads to a reduction in length of stay and economic, right? Like many of these patients were paying out of their pocket. They may be continuing to pay out of their pocket, and the only way to reduce cost, and the bottom line, is to make sure that there are no complications, because each complication increases cost and puts the patients back. So this is actually a picture of one of my good friends who practices in Argentina, who is showing this patient trying to get them out of bed the same day, like a few hours after the procedure. And that is the entire intent of an anesthesiologist. This is a few years back when we used to do epidurals for Roux-en-Y's, and now it's like, you know, completely different ballgame, right? We've come such a long way compared to a few years ago. And that's partly because of the type of bariatric procedures that are being performed. While we used to have a lot of Roux-en-Y's in the past and SADIs, now most of the bariatric procedures are sleeve gastrectomies that are relatively lower trauma to the patient's system, which leads to a higher, faster recovery. Now, I want to start focusing on the anesthesia aspects of ERAS, and our focus truly is, as an anesthesiologist, to have a completely awake and a fully reversed patient that leads to kind of an early extubation. There should be really no time. If it's a robotic procedure, we know that there is no suturing time. Laparoscopic procedures, there's no suturing time. So if we micromanage our anesthetic in a way that we have a fully awake and a fully reversed patient on the table within a few minutes at the end of surgery, you know, that is a good success. And for that, we really have to focus on certain aspects. And as has been alluded from the previous talk, it's really important that we minimize opioids. So it's either an opioid-sparing anesthetic or an opioid-free anesthetic. And it's really possible to do a completely opioid-free anesthetic. I've done them. I can vouch for them. And there is a protocol that needs to be followed. Another aspect is we are dealing with patients who have low lung volumes just because of their body habitus, right? These are patients with morbid obesity, so they come with low lung volumes, even some amount of basal atelectasis. So to ensure that these patients actually, their lungs are expanded, which leads to reduced atelectasis, reduced pulmonary complications over the next several days, because one of the readmission causes can be pneumonia or atelectasis. So to make sure that recruitment maneuvers are given to the patient at regular intervals during surgery. And the advantage of bariatric procedure is that the patients are in reverse Trendelenburg position. So, you know, it's really beneficial to the patient's lungs overall. Postoperative nausea, vomiting prophylaxis, I'll go in a little bit of detail, but the two main anesthesia-related causes of readmission are pain and nausea and vomiting. So if we can really control them really well, then the chances of readmission are much smaller. We heard talking about early catheter and drain removal. Many surgeons don't even put drains. Early oral nutrition, there's going to be a talk of early oral nutrition post-operatively and avoiding nasogastric tube, but also early ambulation. And like total joint replacements, we know that the requirement of a patient to go home after a total joint is a physical therapist makes sure that the patient has enough lower muscle strength to be able to get out of bed and walk. And we should not assume that just because a patient has a high BMI, they are not frail. We have a lot of frail patients with morbid obesity because they don't have the muscle mass to. So to ensure that with a physical therapist that the patient can actually truly support themselves and ambulate, especially when they're ambulatory surgery, right? They're going home. We're not going to be seeing them the next morning. So to ensure that the patient's able to ambulate before they go may be a very essential part of ambulatory procedure. And And all of this essentially leads to high patient satisfaction. One of the main things is, like Dr. Billing said, preparing the patient physically, mentally, and psychologically to make sure that they know what they're going to go through, what is going to happen, they're fully aware. So patient satisfaction is very important. Now, as far as intraoperative care is concerned, what do I feel is really important we as anesthesiologists should do to make sure that the patient go home? Now, compared to what the beliefs in the past were that patients with obesity have difficult airways, we know that's not necessarily true. There's only a small percentage with difficult airways, but we need to recognize those patients, those small percentage of patients who will have difficult airway and be adequately prepared for that difficult airway. The other is making sure we give opioid-sparing anesthetic. Personally, I like to use, I used to use a lot, as if I have 2 hours available to me, I'll give them oral analgesics preoperatively, like PO Tylenol, PO Celebrex, maybe gabapentin. But if you do not have those 2 hours, remember the patients are having gastric procedure and you don't want a tablet stuck in the staples. So if you don't have the time to give PO analgesics, just do it all IV. And you can give IV paracetamol, IV ketorolac. As if we are in South America, you may have IV paracoxib, which we don't have in North America. But two of the most important medications for an anesthesiologist in these patients is IV ketamine and IV dexmedetomidine. And the advantage of these two medications is they do not affect the upper airway. Genioglossus muscle activity in the upper airway has shown that it doesn't get affected by these two medications, ketamine and dexmedetomidine. And it allows us to completely eliminate opioids from our medical care. So I strongly recommend these two medications. Normothermia, even if it's a 1-hour surgery, patients with obesity do have a prevalence for hypothermia. And I heard the previous speaker, Dr. Billings, say 2 to 4 liters of fluids. But my argument against that would be that if we allow the patients oral fluids until the morning of surgery as a part of ERAS protocol, and ask them to take 2 bottles of pre-surgery Ensure, which is 800 mLs of oral carbohydrate, like low glycemic carbohydrate solution the night before, and 400 mLs on the morning of. My recommendations to the patients is take that 400 ml as you get into the car to come to the hospital, and that's about 2 hours before surgery. So if you have a really well-hydrated, orally hydrated patient, you don't need to give the 2 to 4 liters of IV fluid. And another point is making sure that the patients have quantitative train of 4 monitoring, because these patients need paralysis, right? I mean, we have to intubate them, so they are paralyzed, and there is very little suturing time. So at the end of surgery to extubation has to be very small time. And if we have a quantitative train of 4 monitoring to make sure that we have completely reversed our patients, then we have a lower chance of post-op pulmonary complications. And I'm going to quickly go through like some of the main points of airway management and other managements. We don't have a lot of time, but making sure our patients are pre-oxygenated in a head-up position. Some patients may need between 5 to 8 minutes to be adequately pre-oxygenated. So as soon as the patient comes to the room, put the oxygen on and then put the monitors on so that there is no waste of time. And now we have technology available to make sure that our patients, even very, very high BMIs, like BMI more than 50 or very high adiposity, don't get hypoxic. So this actually is a picture of high-flow nasal cannula that gives between 30 to 70 liters of oxygen through the nasal canal as we are trying to intubate the patient. And if you have this high-flow nasal cannula in the nose, the chances of them getting hypoxic, even if the intubation time gets prolonged in a very difficult airway, and I'll show you some pictures where there's no way the patient's airway can be normal, this will allow your patient to have no complications related to hypoxemia. The other, if you don't have a high-flow nasal cannula, if you can just have nasal cannula, just the regular nasal cannula at 5 liters per minute in the patient's nose, it will again improve your apnea time and reduce the chances of hypoxia. The last technique, again, very simple. You don't need to get very fancy, but a ray tube, which is a right-angled tube, if you just tape it on the patient's side of the mouth and run 10 liters of oxygen, the end of the tube is going to be very close to the vocal cords, and it allows the patients that prolonged apnea time, just in case your patient has a very difficult airway. And lastly, if the patients are really, really CPAP dependent, and again, we heard Dr. Billings say how sleep apnea patients can be really, truly dangerous and the highest risk patients, we can use a nasal CPAP mask on the nose and put them on a CPAP while we're intubating the patients. And this is an example of the patient I personally took care of. She was in extremely difficult airway. We used a high-flow nasal cannula. We made sure that we used a combination of a glidoscope, a video laryngoscope, and a fiber optic scope to be able to intubate them. And she was intubated within 90 seconds after putting to sleep. So we had her very, very well prepared. And lastly, always have a second generation laryngeal mask airway available. And the reason for a second generation laryngeal mask is that it has a gastric port, and this tip of the LMA sits in the esophagus. So if there is any aspiration that happens, in case of an emergency, if you have to use this, it's best to use a second generation LMA so that any regurgitation from the stomach comes right out of this drain tube. So it's best to have a second generation LMA available in case. Lastly, reversal of because we need deep neuromuscular blockade, ensuring full reversal. And now we have good technology available in the market. This is an example of an electromyogram, which actually precisely gives the amount of paralysis there is to the patient. And it's usually used, so it measures the action potentials evoked by nerve stimulation. Different muscles can be used. This is the ulnar nerve, and it precisely tells you that the diaphragm has actually recovered from the patient. Now, this is truly a replication of Dr. Billings' slide, because that's exactly what we use for post-operative nausea and vomiting. When patients were asked how much were they willing to pay to not be nauseous, they were willing to pay $100 out of their pocket not to be nauseous. And so scope patch and aprepitant preoperatively, intraoperatively opioid-free anesthesia, dexamethasone, 5-HT3. It is better to use granisetron if you have available for these patients, because it's a much longer acting medication than ondansetron. And then a low-dose propofol infusion can be amazingly useful to reduce nausea and vomiting. Post-op as a rescue, I personally like to use metoclopramide, promethazone, droperidol, Solutab. So instead of using a repeat dose of Zofran or ondansetron, it's better to use a Solutab as it's a lot more effective. And then using a long-acting medications like scopolamine patch, aprepitant, and granisetron may avoid post-discharge nausea and vomiting also, because we have to be very aware of the PD and V. And lastly, use of regional anesthesia techniques. This is an image of TAP block, which is a transverse abdominoperineal block, but also now the surgeons have a device called M-Close available, where they can actually inject into the TAP, the muscle between internal oblique and transversus abdominis, and they can do the TAP block themselves as the scope is coming out. And thank you very much for your attention.
I have a quick question for you. How often do you use regional anesthesia?
We used to use it a lot, actually, in almost every patient. But we realized that actually surgeons injecting local as they're coming out with the laparoscopic procedure actually does the same thing. So to reduce the time, especially in ambulatory surgery, I think the surgeons can just inject it in the fascial plate.
I was referring to like scapular blocks and all those that some anesthetists are quite fond of.
We have never used scapular blocks for bariatric procedures, I must say. We use them only for shoulders. Bariatric procedures, we mostly use TAP blocks, transversus abdominis blocks. Happy to answer any more questions. I'm sure there are no anesthesiologists in this audience.
Well,
So please join me in welcoming our next speaker, Mary O'Kane. She will talk about a really important topic, which is what is the ideal nutritional postoperative care. Mary O'Kane, she is an honorary consultant dietitian in adult obesity at Leeds Teaching Hospital and past president of the IFSO Integrated Health Section. She has been a key leader in developing national and international bariatric surgery guidelines, including the 2020 BOMS update. Thank you very much.
Thank you. Thanks for the introduction and thanks for the invitation to be here as well. I have no disclosures, but obviously I'm biased, I'm a dietitian, so that will be what I'll be covering. Now, when we look at the post-operative nutritional care, it isn't just immediately after surgery, it's actually it's in the longer term as well. So it's going to be a bit of a whistle-stop tour through what we cover as a dietitian. Now, initially, after surgery, patients will usually start on liquid diet, progressing onto blended food and then onto more normal textured food. And the reason for this is just purely that if the patient does not eat slowly and does not chew the food well, it's going to get stuck. So it's easier to actually help the patient, support them make this transition. So encouraging them to eat slowly, we also need them to actually make sure they keep hydrated. And the problem can be when they start on small amounts of blended food or solid food, they have difficulty keeping hydrated, and especially in the early weeks when maybe they're having to take medication in liquid form as well. So there's lots of changes for the patient. They've got the reduced stomach capacity, but also taking it gradually, it helps reduce nausea and also helps prevent vomiting and regurgitation. Because often patients will talk about they're used to eating until they feel very, very full. We're trying to get them familiar with the new feeling of fullness and also trying to make sure they don't overeat so they don't get that abdominal pain. And there is evidence to show that if the patient has that early dietetic support, they're less likely to be readmitted as well. What I'm always concerned about initially is that patients often do not feel hungry, which is great, but then they may choose not to eat either because they don't feel hungry. Also, because they've got to eat different textured foods, this is maybe when you realise that they can't cook or they don't know how to plan their meals ahead. And also because of the weight loss, maybe on the preoperative diet in those very early stages, they're already starting to get afraid that the weight loss is not going at the same rate, it's getting slower, which I'm relieved at as a dietitian. And they sometimes can be afraid of weight regain, even in the early stages. Common problems are eating the wrong texture of food, eating too fast, but also as a dietitian, very carefully looking for any sort of signs of stricture, or even sometimes the band has been over-tightened and needs to be loosened. It's really important that patients are aware that vomiting and nausea continuously are not normal, and we're always fearful of the thiamine deficiency, and more importantly, the severe side effects of this. It can happen very, very quickly. I've had one patient who thought she had gastroenteritis, didn't contact us, got admitted, ended up on an outlying ward, wasn't started on thiamine or Pabrinex, and ended up with thiamine deficiency. So it's really important to advise the patient and make sure that all hospital staff are aware of the risks. Also, we're encouraging patients to take vitamin and mineral supplements afterwards, and we'll always gear those to the surgery that they're having. And I won't go through those in detail because there are very good guidelines around, including the SMBS guidelines. But being aware that when patients have a very malabsorptive procedure, such as the one anastomosis gastric bypass with a long bilipancreatic limb, the duodenal switch, the SADIS, they're also going to need additional protein, but also additional fat-soluble vitamins, and they're not always available in all countries. Supplements must be affordable because some patients can't afford them, and I know in some countries patients will have to pay for their blood tests as well, so that can be a barrier. When, as a dietitian, we're looking for adherence to vitamin and mineral supplements and looking for those barriers, but also including the patient in a decision making. And so if they don't like the one they're on, what other alternatives can we actually recommend? And again, just mentioning that it's not just about patients having the supplements, we have to monitor those blood results. Protein, all our patients know they've got to have a good protein intake. And this recommendation about at least 60 grams more when they've got a very malabsorptive procedure has been around a long time. However, in reality, many studies show that patients, even after 3 months, are not hitting that target. But also, we have patients, because they know that protein is important, they have such large amounts of protein, they haven't got a balanced diet, and the energy intake might be very low. So again, that dietetic support's important. When I very first started in bariatric surgery, which is actually in the early 80s, I was used to surgeons saying, patients like healthy food. They eat healthily now. They don't like unhealthy food. What we now know is that isn't actually true. People go back to the foods that they're familiar with. They continue to eat the same sorts of food. So if the diet was really high in fat, low in protein, the chances are that's what the patient will end up eating later. So they need that support to actually eat that balanced diet. We also, in the UK, and I think probably in other countries, patients will develop their own language, and they talk about foods being slider foods. So that's crisps, biscuits, chocolate, all slide down easily. And they'll also talk about the healthy food that they've got to eat slowly and chew food well, chew it well is actually difficult, especially when you find out they have no back teeth and they can't do that. And then also people who are binge eating. There is evidence that surgery helps people with binge eating, but unfortunately they may start to graze and snack instead. So again, that dietetic input and support is really important. This study that came out a few years ago showed that the habits that people have that help with people to lose weight but also to avoid weight regain means recognising that they're feeling full to stop eating, to not graze, and they will get a greater weight loss. Obviously, a low-fat diet, being active is really important, but recognising that some people will need more support than others to actually make those changes. Later on, patients may develop reactive hypoglycemia, and this can present quite early after surgery, but I've had patients who've presented first time about 3 years after surgery, especially if they've been pregnant and they've had an oral glucose tolerance test. The first steps are always dietary manipulation, but being aware that patients will likely to be referred on to an endocrinologist, especially if the dietary manipulation doesn't work, and there are good guidelines on that. Many women are going forward aiming to get pregnant, and they need that preconceptual care. In reality, we know that many women will get pregnant quite early, and they'll need that timely support as well. And then just talking about bone health, and I think especially because many people going forward for surgery are women, we know that the more malabsorptive procedures are going to result in a greater risk of fractures. And we know diet's important, but actually aerobic exercise and also resistance training, so actually getting the patients to do that very soon after surgery is really important. Finally, weight maintenance, very important. This is an infographic that we did for EASO, just about the behaviours that are associated with weight maintenance as well. So that's a bit of a whistle-stop tour through dietetic follow-up. So it's not just about those early stages, it's about making sure that patients have access to timely care, psychological support, and actually when they need it, they can actually come back and see us and actually get that specialist advice. I'm hoping I'm on time, but I can't actually see the timer at all. Thank you.
Any questions for Mary? Mary, do you recommend your patients to have interval bloods to check their nutrition?
Yeah, obviously having it preoperatively so we know what the starting point is. And then we'd recommend some routine bloods, maybe 3 months after surgery, 6 months after surgery, and then a year. But what we're also looking for is that how have they responded to those nutritional supplements? Have we given them enough iron? Have they got enough vitamin D? Do they need more vitamin B12? And then after that, it's annual bloods. And that's often when we find out the patient isn't taking their supplements. The B12 has dropped, the vitamin D's dropped, they've been diagnosed with anemia. And we usually just end up having a bit of a laugh with the patient saying, you've been caught out. So yeah, the nutritional bloods, people focus on the supplements, but the nutritional bloods are equally important.
So, one question. Do you have a special consideration for young females undergoing gastric bypass instead of a sleeve gastrectomy?
Instead of what, sorry?
So in terms of how aggressive will you be with the supplementation, the vitamin D, the B12?
Yeah. I mean, I've worked in the field for a long time, so we've had many successful pregnancies, and especially with the Romae gastric bypass. And I think it's a safe procedure, providing patients are managed well. The ones that scare me are when patients have the one anastomosis gastric bypass with a long billopancreatic limb, the SADIS, the duodenal switch. In these, we used to do a number of duodenal switches, and although we advised women not to get pregnant, we had 8 who got pregnant within the first year. One was actually must have been pregnant when she had surgery. Fortunately, very good outcomes, but the vitamin A really scares me because they need high doses of vitamin A, and in pregnancy, that's contraindicated. So I think for the very malabsorptive procedures, got to be really careful and talk to the women about not getting pregnant, and actually question, is it the right operation for them if they're going to get pregnant soon? Yeah.
Thank you, Mary. It's my pleasure to now invite the next speaker, who is also my moderator, Dr. Francesco Alvarez, who will talk about implementation of ERAS after pandemics.
Bueno, va a ser en español esta clase. Lo que voy a tratar de hacer en los siguientes 15 minutos es hacer un breve recuento de cómo fue mi experiencia en la implementación acá en Chile del protocolo ERAS después justo de la pandemia. Y la verdad es que la pandemia de COVID significó una disrupción sin precedentes en los sistemas de salud a nivel mundial. Y en ese escenario la cirugía bariátrica, a pesar de que en ese momento era considerada netamente electiva, pero tenía un alto impacto en la salud pública, no solo por su rol en la reducción de la mortalidad y de las comorbilidades asociadas, sino también se vio profundamente afectada desde la suspensión total de las cirugías electivas hasta la consolidación de la cirugía bariátrica ambulatoria como un nuevo estándar de seguridad. No tengo nada que declarar, y aquí quería contarles un poquito cómo fue que vivimos acá algo pasó acá. Para enero del 2020 empezamos ya a escuchar acá casos en China que empezaron a hablar de este virus nuevo, y después de eso vino una rápida propagación global de la pandemia, con un sistema de salud, como les decía antes, que no estaba preparado y que obviamente afectó gravemente las intervenciones quirúrgicas electivas, ¿ya? En ese minuto se empieza a escuchar ya que la obesidad es un factor de riesgo per se para la gravedad del COVID, al igual que la diabetes tipo 2. E inmediatamente las sociedades mundiales empiezan a ponerse de acuerdo y a tratar, con los pocos datos que había, la poca experiencia que había al respecto del COVID, a tratar de dar algunas recomendaciones a seguir en términos de el triaje de los procedimientos bariátricos durante la pandemia, y de alguna forma hacer un circuito específico dedicado a pacientes con obesidad mórbida y que tuviesen COVID al momento de la intervención o no, ¿ya? En cirugías de urgencia, obviamente. Y por supuesto surge en primer momento la necesidad de reforzar la telemedicina, que hasta ese momento era bien débil, por lo menos acá en Chile, como una estrategia de continuidad asistencial tanto desde el inicio del preoperatorio hasta el postoperatorio inmediato, ¿ya? A su vez, todos los que estábamos involucrados en los equipos de bariátrica empezamos a pensar cuál iba a ser la estrategia futura para cuando en algún momento se levantara la restricción de la cirugía electiva. Y la gran preocupación era, en el fondo, ¿cuándo vamos a reiniciar esto? Cuando bajen las fases agudas, las fases epidemiológicas muy agudas de la pandemia. Entonces empezamos a ver el famoso aplanamiento de la curva, que se acuerdan, ya todos nos olvidamos de eso, pero estábamos todos pendientes de cuántos casos había en el día, cuántos casos había en la semana, porque eso dependía en el fondo que pudiésemos volver a operar en algún momento. Y la verdad es que yo creo que enfrentamos una oportunidad increíble que no nos dimos cuenta en ese minuto, pero la verdad que el COVID nos sirvió para impulsar un cambio sistémico del sistema muy importante. Mientras estábamos en Europa, la suspensión fue total de la cirugía, reiniciaron cuando empezaron las cirugías electivas con PCR, obviamente, un circuito COVID-free y hospitalizaciones cortas, ¿ya? En América Latina, en Argentina, tienen reportado hasta el 90% de suspensión de la cirugía bariátrica y un alto uso de telemedicina también. Y en el fondo en Chile lo que pasó fue que la Sociedad de Anestesia y la Sociedad de Cirujanos de Chile se unieron y hicieron una recomendación primero. Esta recomendación fue en abril del 2020. Y en el fondo lo que decía básicamente lo mismo, una renovación escalonada de la cirugía y por supuesto priorizando la cirugía ambulatoria. Ese es el statement de la sociedad. Y en este momento, cuando hacen este acuerdo y estas recomendaciones, ponen a la cirugía bariátrica como una cirugía electiva pero discrecional. En el fondo no tenía ninguna urgencia para operar y solo quedaron las urgencias y las patologías oncológicas para resolverse. Por lo tanto, hasta este minuto del pronunciamiento de las sociedades tampoco estábamos operando cirugía bariátrica. Después, la Sociedad Chilena de Cirugía Bariátrica y Metabólica también hizo esto ya fue en julio, ya habían pasado 4 o 5 meses, en la cual se une a la propuesta de la IFSO también, y en el fondo la idea era empezar a operar cirugía bariátrica en las comunas, en los lugares donde tuviera menos carga viral la población, ¿ya? Entonces, en el fondo lo que se hizo fue, solo en la fase 0-1 de la pandemia, solo cirugía ambulatoria, que era una principal restricción, porque para ese momento nuestros pacientes bariátricos se quedaban aproximadamente 2 o 3 días. Entonces, para poder empezar a operar, teníamos que hacerlo de forma ambulatoria que se fueran el mismo día, ¿ya? Que era un cambio que uno ahora lo ve como muy fácil de hacer, pero en ese minuto, empezando por los pacientes, ninguno quería irse para la casa el mismo día. Segundo, las aseguradoras no cubrían todo el monto de la cirugía si la cirugía era ambulatoria en muchos casos, sino que tenían que quedarse hospitalizados. Así que tuvimos ciertas barreras para lograr esa ambulatoriedad que queríamos, ¿ya? Sugerían pacientes menos de 65 años, obviamente, ASA 1-2, con un índice de masa corporal menor de 30, PCR negativa reciente de 2 a 3 días, y bueno. Entonces la gran pregunta era ¿cuándo y cómo reiniciamos la cirugía bariátrica para que nos dejen hacerlo en los hospitales o en las clínicas? Y cómo seleccionamos a nuestros primeros pacientes para no tener malos resultados y no tener problemas con estos pacientes y el COVID aparte. Antes de seguir, esto se lo puse básicamente para ver, todo esto lo que influyó fue que hubo una acumulación de pacientes bariátricos durante todo el año 2020, y este estudio lo muestra muy bien cómo en el año 2021 aumentan las cifras descabelladamente con todo lo que había quedado acumulado de la pandemia. Sin embargo, el siguiente año tampoco fue suficiente para saldar todo lo que había quedado pendiente. Sin embargo, en este registro lo que sí se dan cuenta es que la estadía disminuyó más o menos entre 1,3 a 1,4 días, la mortalidad se mantuvo estable y, por supuesto, que todos seleccionando siempre pacientes más jóvenes y con menos morbilidad, ¿ya? Les voy a pasar a contar un poco lo que fue mi caso. Ya yo había leído en el 2019 este trabajo de LAM en San Diego, y ellos lograron un 83% de alta al día postoperatorio 1 en manga laparoscópica, sin aumento en las complicaciones y sin ningún reingreso tampoco. Y las claves era adherirse a un protocolo ERAS, modificado, pero líquidos en la unidad de recuperación, analgesia multimodal en el intraoperatorio y preoperatorio, obviamente, sin sondas ni drenaje y la movilización precoz, ¿ya? Entonces lo que planeamos nosotros fue en el fondo hacer de alguna manera algo que fuera seguro para los pacientes y para nosotros que estábamos todos traumatizados con las máscaras N95, reducir las complicaciones, obviamente, optimizar los recursos del hospital que estaban con crisis de materiales, obviamente, y acortar la estadía hospitalaria lo más que pudiera. Afortunadamente, después de ese estudio del AM, en la clínica donde yo trabajaba en ese momento, yo empecé a que quería mandar a todos los pacientes bariátricos para la casa. Y la verdad que tuve harta reticencia del equipo en general y de la institución también. Entonces lo que hicimos fue que nos conseguimos permiso para hacer un piloto al principio eran 20 pacientes, después nos pidieron que hicieran 10 más, hicimos 30 pacientes. Y en el fondo lo que hice fue que evalué la intención del alta. En el fondo el paciente entraba en una vía normal de hospitalización y yo lo seguía, le hacía toda la visita preanestésica, le hablaba con él, le aclaraba las inquietudes, etcétera, etcétera. El paciente se operaba y se quedaba hospitalizado una noche. Y antes de esa noche yo iba y evaluaba en el fondo la intención de alta del paciente, si es que él se iría a la casa o no, y si estaría cómodo y se sentiría cómodo yéndose para la casa. Y en el fondo evaluamos dolor, que hubiese caminado, que hubiese tolerado los líquidos orales, nada más que eso. ¿Ya? De estos 30 pacientes le hice yo la visita preanestésica telefónica en el 100%. De ellos, el 80% cumplió con la premedicación, que básicamente era un antiemético de nueva generación de larga duración, como el quincio. Pregabalina, paracetamol, ketorolaco y obviamente la carga de carbohidratos. Le hicimos una carga bien rústica que la hacíamos con Gatorade azucarado. ¿Ya? 4 horas antes y 2 horas después. Tuvieron escaso requerimiento postoperatorio de opioides. De los 30 pacientes, solo 4 tuvimos que reforzarle en el postoperatorio. En ese minuto yo usaba morfina para la analgesia. No tuvieron náuseas ni vómitos postoperatorios y el 100% de los pacientes estuvieron en condiciones de alta antes de las 24 horas. ¿Ya? Les cumplí el control telefónico a todos, como el doctor Billing, y no tuvieron ninguna complicación y ningún reingreso. Eso hizo que nos autorizaran de alguna manera a empezar la cirugía bariátrica ambulatoria con alta el mismo día. Y ese fue el protocolo que empezamos haciendo, con todos los pasos de ERAS, obviamente, una fase preoperatoria, la fase perioperatoria, la carga de carbohidratos y los analgésicos, las fases de cuidado intraoperatorio, esto lo he ido cambiando un poco en el tiempo, pero esa fue como la inicial. Y también utilizando, como decía la doctora, obviamente, ketamina, paracetamol. El Presedex no lo utilizamos por una cuestión de costos más que todo, pero en algunos casos también lo podíamos usar. Postoperatorio inmediato, obviamente con levantada precoz, con quine precoz, con realimentación hídrica, con agua precozmente también en la recuperación. Y en el fondo, si a las 6, 8, 10 horas estaba listo para irse, le hacíamos la evaluación, que tuviera la capacidad de tolerar la dieta oral, que pudiera caminar de forma independiente, que tuviera buen control del dolor y que hubiese... y le poníamos un suero fisiológico en ese minuto, 500 ml, para que se fuera a la casa más hidratado en caso de que no hubiese consumido mucha agua. Y el seguimiento y soporte que lo hacíamos nosotros mismos. En el fondo esto se los digo porque cuando uno trata de implementar un programa de esto siempre cree que tiene que hacerlo bajo el alero de la institución con un gran sistema de registro, con una enfermera que esté dedicada solo a esto y la verdad es que cuesta mucho partir así. Es mucho más fácil partir así y después extenderse, ¿ya? Entonces nosotros más o menos tuvimos los mismos criterios, en menos de 50 años, índice de masa corporal 35, esto era para manga, y menos de 40 y menos de 65 para los otros procedimientos bariátricos que no están incluidos en esos números, que era el balón y la gastroplastia endoscópica que se hacía en ese minuto. Partimos haciendo escáner de tórax a los pacientes porque lo leímos en alguna cosa de Italia y a corto andar nos dimos cuenta que no tenía tanto rendimiento como creíamos, así que nos quedamos solo con la PCR. Obviamente la protección necesaria de siempre, la N95 y doble protección facial o máscara full face. Y lo que hicimos sí fue integrar del todo la educación de los pacientes en el preoperatorio. Yo me daba mucho tiempo para conversar con ellos antes, explicarles las dudas, explicarles cómo iba a ser el sistema, cómo iba a llegar por su vía, cuándo se iba a ir, que no se iba a quedar hospitalizado, etcétera, etcétera. La carga de carbohidratos, la analgesia multimodal, le damos el alta el primer día y después postoperatorio. Definitivamente, bueno, como lo han dicho todos, yo creo que fundamental la telemedicina nos tocó en la pandemia y llegó para quedarse. Hoy en día es mucho los cirujanos que hacen telemedicina a sus pacientes antes de verlo en la consulta. La analgesia optimizada, que de alguna otra manera yo no soy muy fan de hacer la cirugía bariátrica sin opioides, pero uso opioides, a diferencia de mucha gente, de larga duración, que después los vamos a ver, y antiemesis de última generación. De todas maneras, yo creo que eso fue un cambio súper importante con el aquincio, que nos puede durar hasta 3 días, eso nos da una gran tranquilidad. Manejo de expectativas fundamental y el control postoperatorio. Las lecciones aprendidas, básicamente lo mismo. Yo creo que en la rigurosidad de la elección de los pacientes y la misma educación del paciente es un potente analgésico y un tranquilizador para el paciente, que sepa a qué va a llegar y cómo lo va a hacer, ¿ya? Si yo tuviera que resumir la experiencia que tuve yo en el COVID con la cirugía bariátrica, yo creo que la pandemia no solo nos interrumpió, sino que nos empujó bruscamente hacia el futuro de la cirugía bariátrica. Lo que venía en unos varios años más lo tuvimos que hacer en pocos meses. Hoy sabemos que la cirugía bariátrica ambulatoria es segura y se puede reproducir fácilmente con protocolos ERAS simples. Y al final lo transitorio que tuvimos se convirtió en estándar, y lo que parecía ser una crisis terminó siendo un acelerador de toda la cirugía bariátrica ambulatoria. Eso.
Okay, any questions? Okay. Thank you for your talk, Dr. Alvarez. It was super clear for everyone. So our next speaker is Andrea Schroeder. She will talk about the life after bariatric and metabolic surgery. Well, you have learned from your patients, right? She's a registered nurse with over 26 years of experience in metabolic and bariatric surgery and president-elect of the IFSO Integrated Health Session. She leads tailored clinics in New Zealand, where she has developed holistic, lifelong programs to support patients before and after bariatric surgery.
Thank you. Here. Okay, nothing to disclose. So I'm actually not going to be talking about ERAS as such, but I'm going to be talking about a less traditional approach to follow-up as a result of what my patients have taught me. So I'm going to outline my experience as a nurse and a retreat facilitator, the importance of the integrated health team, what my patients have taught me and what I have learned, and the importance of comprehensive follow-up, aftercare and support. So I've been a bariatric nurse for 26 years, so 4 years in Australia and 22 years in New Zealand. And I've seen the challenges of patients living with obesity even after surgery. We run a residential retreat program in New Zealand, and so I've had the absolute privilege of living with my patients and hearing their stories of trauma, of shame, their family situations, which are often have trauma and as a foundation, their vocations, the issues they have with employment, the experience of stigma and bias, whether that's been implicit or explicit, or even the internalized weight bias. And those things have taught me compassion and understanding for my patients. It's been over 13 years since we started residential retreats. So we have previously a 5-day program, but now a 3-day program where our patients come and live with us, and we teach them all about self-awareness, self-love, self-care, and it's all acceptance commitment based, but it's got a nutrition and an exercise component with it. But being able to spend that time with our patients means that we get really intimate with them, and we actually learn a lot of what's going on for them. And I've done 20 plus years of providing patient support. So the importance of the integrated health team, I think over the last few days here, we've had that pretty much drummed into us that we need a multidisciplinary team for our patients to get the most out of their metabolic and bariatric surgery. But we do know that all of the team needs to be collaborative in their care, and they need to provide education, resources and support to ensure sustainable patient outcomes. So we need everybody working together, not working in silos, and so that we work together as the team. So from a nurse's perspective, I just wanted to outline, I guess, why I have been privileged to be able to learn some of this information. And I think that's because patients often perceive the nurse as the least scary and the most trusted of the team. Certainly, they can tell us things that they wouldn't dare tell the psychologist because, they want that positive impression and phenomenon. But they're able to feel like that they can confide in us because potentially we're not the ones that are going to make the decision about whether or not they have their surgery. And because of this, I've been able to have a real understanding of how their history, their trauma, their family situations, the shame, and the negative experiences impact their quality of life, their lack of self-love and self-worth, and that results in challenged self-efficacy. So the title of my talk was "What Have My Patients Taught Me?" So I'm just going to outline them here. Most of our patients, and I'm going to say a fair degree of our patients, maybe 80, 90% of our patients, carry deep histories of shame, of trauma, or difficult family dynamics. Eating is often more than hunger. It's been years long of self-soothing, self-comfort, or even just survival on how to deal with the trauma that's been in their lives. Self-awareness, self-love, and self-care is not intuitive. This is something that needs to be learnt, so it needs encouragement to be taught, and it needs to be experienced to be able to identify the things that come up for them. Our patients frequently need help to identify and then address the factors that contributed to their excess weight. And ongoing follow-up and community or team-based support is essential. So what have I actually learnt from this? Is that this sounds a bit repetitive, but I'm going to give it to you in a different perspective about what I have learnt. So trauma, especially early in childhood, is common, and it manifests in self-sabotaging behaviours, things like comfort eating or overeating. Patients frequently experience some level of emotional dysregulation, and they need tools and strategies to either control it or to help them resolve it. Self-awareness, self-love, and self-care need to be taught, and we need to teach it to our patients as soon as possible. Healing isn't just about surgery or nutrition or exercise. It's about learning new ways of patients relating to themselves. And long-term sustainable weight loss and improved health, which is both mental and physical, needs comprehensive follow-up and support. So the comprehensive follow-up aftercare and support slide will show you that long-term success is not just about the operation, but it is about the follow-up, and that follow-up needs to be multidisciplinary, and it needs to continue for as long as you can provide it. They need a comprehensive multidisciplinary team, and that includes all of the disciplines, all of the specialties. So we've got medical, we've got nursing, we've got psychological, nutritional, exercise, and it also includes peer support. So we try and set our patients up with other patients so that they're not feeling like that they're doing this on their own, that they've got other people that are going through the same thing. Compassion and understanding by the whole multidisciplinary team must be at the centre of care. This is the only way that we can reduce the stigma, build trust, empower our patients, and let them have long-term sustainable success. So what does this look like? So this is what we do in our practice in New Zealand, and I know that not everybody doesn't have the same access to these resources, so don't let it put you off, but this is what we've been able to provide for our patients over the last 20 years. So they get a 2-year comprehensive follow-up and aftercare from the multidisciplinary team. We have a surround care program or fee-for-service aftercare appointments, and these can be face-to-face or remote or virtual. So that surround care is just an aftercare package. So we have a big issue with medical tourism in New Zealand. So people go to other countries that are cheaper than what it costs in New Zealand. So we have a lot of people that go to Turkey or Thailand or Mexico. They have their surgery there, they don't get any follow-up, and then they can come to us and buy a surround care package. We have the residential retreat program that I was talking to you about in my earlier slide, and this, as I said, is part of our patients' packages. So when they come and they have surgery with us, they buy the 2-year package of follow-up, and they also get the residential retreat as part of it. It's a very experiential program, and it's such a pleasure to be able to watch the transformation of them over the 2 to 3 days that they're there. We run support groups. We call them walk and talk. So we meet up with our patients once a month, and we go for a walk. And so we offer, our team comes too, and we can talk to our patients about anything that they might feel uncomfortable about speaking to us in the clinic. We have a number of resources. We provide webinars, seminars, masterclasses. We put out a monthly newsletter. We have blogs on our website. We have a big online community that is through Facebook. We have our own recipe books, our own portion control plates. We have apps and exercise cards, and then there's a patient manual and an online patient portal, which is just a place where they can get all their information. They have very good access to vitamins and supplements. I own my own vitamin supplement company, and so we sell those out of our practice. Our patients can come in, and every time they come in for their follow-up, they have access to bariatric quality vitamins. They know that they've got all the appropriate micronutrients because we manufacture them ourselves. We also offer a medical program with a multidisciplinary team, and this uses the obesity management medications as part of their program, but they can't go through that program unless they see the multidisciplinary team. We don't just do medications on their own. And then we offer another service called annual blood reviews. So we see our patients for 2 years, and then after the 2 years is up, we offer a blood review where they can come in once a year and have their bloods reviewed, and then anything that they need, they can do from there. So what do we need to do to look after our patients appropriately and adequately? We need to treat our patients without shame, without judgment, or without bias. We need to listen to them, and we need to hear their stories, their goals, and their expectations. We need to know that their expectations and our expectations are the same. We need to teach our patients more healthy ways to cope with the effects of trauma, of adverse events, of crises and triggers, things that can potentially set them back after they've had their surgery and make them go back to their old ways of living. We need to be compassionate and passionate, understanding and supportive. And we need to focus not just on weight loss, but on health gain and living life. So I just put this slide up here. It was a bit tongue-in-cheek, actually, and it just says progression, because the theme for Toronto is from weight loss to health gain. But I've got my Taylor Clinic's logo there, and we've had this as our mantra for the last 20 years. Lose weight, gain health, live life. Thank you. Oh, I have got one more slide, sorry. With the right support and compassion, patients can thrive and break lifelong patterns. It's not just about the surgery. A community-based support and follow-up program is imperative and paramount. And I just wrote there, I'm very grateful to our patients for being so open and honest and allowing us to share their journeys. Now I've finished. Sorry.
Thank you, Andrea. That was very interesting. We've got a question coming up, I think.
That was fantastic. Congratulate you on putting that together. I have two questions. Yeah. One is, does the health system pay for this? And if not, how much does it cost? And then secondly, where do you garner or capture your patients? How do you get the word out that this is available?
Okay, so New Zealand is quite unique in that we have 300 publicly funded surgeries for the whole nation. So all of our patients pretty much are self-payers. So we don't have health insurance, so our patients pay 30,000 New Zealand dollars for surgery, which is why we include the retreat as part of our package. But I will say that only about 60% at max of our patients actually come along, even though they've paid for it. And and they don't know what they don't know. So they don't know what, they just don't, you know, and a lot of shame is one of the drivers that stops them from coming. But I guess when only 50 to 60% of them come, it subsidises the ones that do come. What was your second question? Sorry.
Well, I was just wondering how you get patients to know about your service, but you're saying it's part of the process there because it's cash pay. We had about a third of our practice is cash pay, and it included a year of aftercare. And the attrition still is about 30 or 40% in that year, even though they paid for it. And then the second year was another drop, another 30 or 40%. So at 2 years, it was hard to keep people in the programs.
Yeah, and we used to have 50% dropout at 18 months, but we're actually at about 80% of our patients still come back at 2 years now. But we have we've pretty comprehensive social media. We have lots of really, you know, supportive things that go on. But yeah, it is always, and I think one of the concerns about why we lose patients or why patients go overseas is because it's $7,000 to go to Turkey, whereas it's $30,000 to have it at home.
Yeah.
But people come to us because they want the aftercare, and we have the...
our clinic will see anyone wherever they had their surgery. Usually if it's immediate post-op, we ask them to follow up with their surgeon until they're better. But this aftercare is absolutely essential for the long-term success. So congratulations.
Sure. Thank you.
I had a quick question. So what are your advertising modalities for the ones who go out of the country, who don't really, you know, you don't automatically are able to sell your, through the New Zealand system?
It is really difficult. We just use Facebook mostly, and we've got staff who are patients as well, and so they're able to advertise in the national Facebook bariatric surgery groups, but yeah, we advertise things, you know, we try and promote why patients need follow-up and those sorts of things without it being insensitive, but it's it's one of those difficult things.
And what's the cost of that program for the ones who have surgery outside the country?
$3,200.
For 2 years?
Yeah.
Thank you.
Thank you, Andrea.
Going.
Well, it's my pleasure to also invite my other co-moderator to come and give a talk. Dr. Rodrigo Claro is a surgeon from Santiago, and he's going to talk about implementation of ERAS in Latin America.
Okay, so thank you very much for the invitation to talk. I was so happy, but then I remember that the meeting is in Santiago, where I live. So I would like to have the invitation next year. So we're going to split it, half today and half next year in Toronto. Well, so when I was thinking about on giving this talk, I was trying to think about something different on how to introduce to the implementation of ERAS. And then I remember that I read Atul Gawande, this article back in 2011. I don't know if many of you know him, but he's an endocrine surgeon, right? He has written many articles for The New Yorker, and he wrote this one back in 2011, which is called My Personal Best. And in that article, he wrote that even among very skilled and great surgeons, at some point, they stop just getting better. Basically, all skilled surgeons at some point, and probably every one of us in our different works, reach a plateau. We stop getting better. And then he thought that maybe getting coaching could help them to get better, right? And he asked the question why Rafael Nadal, which is like the best tennis player ever, has a coach, and that coach sometimes not even reach to be in the top 10, right? And I believe that at some point, basically, our practice in bariatric surgery, we are in the very same place, meaning in most of our clinics and practices, most likely we are at a very high level in our results, but I think that we can do better. So we are good, but for certain, I believe that we can do better in our outcomes and in our result. So actually, we can reach a higher peak of performance for our patients. And I truly believe that ERAS is the way to go. And I will tell you a little bit more about how this particular program was started at our clinic and which were my beliefs by that time. So can we improve outcomes in bariatric surgery? And why outcomes matters, and to whom, and to all of us, right? So our patients want to have faster and safer procedures. As it was mentioned before, they want to have less pain, no nausea, to have a better experience. So surgeons, we want to have fewer complications. We want patients to be discharged soon, and we don't want to receive any phone call because that means that our patients are doing fine. Our institution also want us to have, the bed available to do like more surgical procedure. They don't want us to have inpatient being readmitted again. We want to have better quality indicators, and of course, for the health insurance company, they want to have safer procedure with low cost. And then you ask the question, so what outcomes should we measure, right? And maybe in surgery, they are always the same. We want to have less complication. We want to have the patient discharged very soon. There are different kind of measuring complication, and some of them measure up to 30 days after surgery, so we don't have to have readmission during that period of time. Of course, we don't want mortality. We want to increase our patient satisfaction, mouth-to-mouth experience in patients also helps us build our reputation as a surgeon and also in our institution. And this is quite striking when you have patients who underwent, let's say, some sort of like a ERAS procedure, and they share their experience with other patients who didn't get the care of the ERAS pathway, and they're like, hey, doctor, why I don't have nausea? Why I'm not vomiting? Like, why I didn't have that much pain that, my friend got when he got the surgery? So this is really what we wanted to do. And as you will see, ERAS can target all of these outcomes. So ERAS, we already heard a lot about what it is, but it is important to remember that there are 4 stages in which elements of care are categorized. So we have a lot of pre-admission, preoperative, intraoperative, and postoperative. And one of the most important differences that I would like you to remember is that when you compare an official ERAS program with an unofficial ERAS program, one of the key differences is that with an official ERAS program, you can audit the data. So basically, you have a software in which you can see live every single day how all your patients are doing, what the result of your institution are in all these 4 stages. So the evidence supporting that bariatric ERAS works is very vast. There are a lot of randomized controlled trials that have shown all of this benefit, right? So we know that you can have to make your patient to stay less time in the hospital, depending on how good your surgeons are in terms of complication. You can also, at some point, can decrease the severity and the number of complications. You can decrease readmission rates. You can decrease the use of opioids, nausea, vomiting. Patients are walking around faster. And the most important thing, when you challenge the system in terms that you are doing things, let's say, more rapidly, you are not increasing this, you are not putting in risk the safety of the patient, right? And that is very, very, very important. So let me show you a little bit about the experience that we had in our clinic. So the first time that they mentioned to us, we want to implement ERAS in bariatric surgery, they have previous experience in colorectal surgery, and they did really well. So they decreased the complication rate, the leaking rates, the readmission and everything. And when they asked us, or basically what I thought was that, oh, we do so well. Like, we don't have complications, like we do pretty much the same thing across all these surgeons. So I didn't saw, actually the first time, like great value on what difference the implementation of an official ERAS program would do for us. And as you can see, the journey in order to implement an official ERAS program in your institution is long. You had to have like weekly meetings with your team. Then you will receive people who is already certified in ERAS program to teach you how to do it. And you can see that our first seminar was in August 2023. Our first ERAS patient was on April 2024. And we have to do a lot of cases before we actually got the official ERAS certification. So it requires a lot of work. And this is really something important. Before and after ERAS, let me show you what we have accomplished. And in this slide, there are like 2 or 3 things that I consider that are super important. So you have the 4 main areas of element of care: pre-admission, preoperatory, intraoperatory, and postoperatory. And you can see our compliance. So basically, you need to remember that ERAS is a checklist of best practices before, during, and after surgery. Basically, what compliance means is that how many of all of these steps we can do, but every time for every single patient. And you see that in the pre-admission, before the implementation of the protocol, our compliance was about 24%, and then it went up to 53%. And also you see a significant and higher increase in compliance in the postoperatory phase. So in our case, before ERAS, I was not that wrong, meaning that preoperatory and intraoperatory, we were not doing that bad, but there was a lot of room of improvement for us in the pre-admission and in the postoperatory. And of course, after the implementation of the program, our compliance rate increases significantly in these 4 categories. And you need to know that, as far as I remember, we need to be like above 80% in all these stages of the process in order to be in compliance with the protocol. And this is just shortly to show you what happened in our program. So for this analysis, we had the last 51 patients that underwent bariatric surgery consecutively, and we compared the result to the first 100 patients after the ERAS implementation. And you can see here that the most significant change that we achieved was the length of stay. This is the median, so we were able to go from 1.2 days to 0.8 days. And without increasing significant complications. And also you can see that we have a significant decrease in the nausea from 32% to 8%, basically. And also what is very interesting is that for us, over 90% of our sleep cases are going home during the same day, and we are not seeing consultation in the emergency department room or readmission, or we haven't have to do like any surgery for a major complication. So then you have like something this good, like an ERAS protocol with all this benefit, right? But we are not doing it. And the problem is that there are many barriers. For sure, the cost, if you want to be an ERAS official site certified, you will need to pay money. That your institution will need to be willing to do that as well. And also when you are implementing all these structures and pathways, you need all the team, all the multidisciplinary team to be in line with these changes in what you are doing, right? Because also surgeons were very special, and we do some things for so many years that we want to change, so it is hard to push your colleague to do something different. But at the end, it works, right? And then we ask the ERAS Society to give us like a number of institutions around the world that are certified officially, and you can see that there are few. Probably there are more, but there are very few institutions, and we are happy that in Chile we have 2 institutions now doing ERAS, but we were the first, right? For a few months only, but we were. There is always competition. And so I truly believe that some ERAS for sure is better than no ERAS. Sometimes people will say that we don't have the resources to, to start an official ERAS program, but and people may ask why start if I am not going to be certified. But let's say that if you do it, even you start with one component of ERAS, you for sure are going to see better result in your patient. Even sometimes only pre-medication, make the recovery of the patient, far, far better than don't giving them like a preoperative medication. And if you talk to people who has the official ERAS versus those who don't have like official ERAS, you are going to fight and discuss, whatever you want. Because when you are official certified ERAS, you have the software, you have your logo, you have so many good things. But I truly believe that the most important one is what I told you before, is the capability of audit. You know exactly every day for each of your patients, how are you doing in all these 4 stages. So ERAS in Latin America, as you saw, certified programs are still very rare in the region. I think that the cost is the main barrier. There are many, many centers that apply the ERAS-like measures with positive results, as we saw early. And I think that you can start small, you can measure your results, and then with data, you can go to your institution and to fight in order to have your own certification. So certified programs are still rare in the region. Cost seems to be the great barrier. ERAS, as I show you, improves patient safety, recovery, and overall outcomes, and also the experience for the patients. And I think, as I told you early before at the beginning of this talk, that I believe that we all can have our personal or institutional best, and we can reach a higher peak in outcomes for our patients. And before I leave, I want to say thanks to the team at our clinic. Thank you.
Thank you, Dr. Carlo. Any questions?
I have a question. Which ERAS certification do you follow? Is it the main ERAS Society or Latin American ERAS Society?
No, so we are certified by the official ERAS Society.
Yes, okay. Wonderful. And what's their current cost for the metabolic and bariatric? Is it it used to be $3,000 a year, so it's not too high, right?
Yes, so I'm not quite sure about that, but in previous talks, I heard, it was about 3,000.
Well, that was a wonderful session of good speakers and great discussion. I'd like to call this session to a close. Thank you very much.